Okay, so this gets us to the next question, that is question number 24. This gets us to question 24. NAC, non-specific esterase, is seen in all except, and the answer is D, that is M6. The answer is D, that is AML M6. Now let us see this in detail. See, non-specific esterase NAC, it is a cytochemistry for monocytes. So obviously this is positive in M4 and M5. That's obvious. M4 stands for acute myelomonocytic leukemia. M4 stands for acute myelomonocytic leukemia, whereas M5 stands for acute monocytic leukemia. M5 stands for acute monocytic leukemia. Next point, so obviously NAC is positive in both M4 and M5. Next, APL, that is M3, acute promyelocytic leukemia. M3, that is acute promyelocytic leukemia, this can also be NAC positive. 25% cases are NAC positive. So it is positive in all, that is M3, M4 and 5, not positive in M6. Next point, this gets us to the FAB classification. This gets us to the FAB classification of AML. FAB stands for French American British classification. You very well know it is M0 to M7. So first point, most common AML M2. Most common M2. What we are writing is a standard set of questions which again have been repeatedly asked. Least common AML. Least common AML M7. Least common M7. M7, this is also called as acute megakaryocytic leukemia. M7, this is also called as acute megakaryocytic leukemia. How do we diagnose M7? It is CD41 positive, CD61 positive. Least common M7, CD41 positive, CD61 positive. Next point, MPO negative AML. Next point, MPO negative AML. They are M0, M6 and M7. MPO negative AML, M0, M6, M7. M6 stands for acute erythroleukemia. M6 stands for acute erythroleukemia. How do we diagnose M6? It is CD36 positive, CD71 positive and glycophorin A. So markers in M6, CD36, CD71 and glycophorin A. Next point, best prognostic AML. Best prognostic AML, it is M3. M3 is acute promyelocytic leukemia. Best prognostic M3, acute promyelocytic leukemia. First point, most common translocation, whichever points we are writing now, they are with M3 only. Most common translocation in M3, translocation 15-17. Fusion transcript, PML RARA. This is the fusion transcript. By fusion transcript, we mean that if a translocation has taken place, it leads to formation of a protein, that is fusion transcript, PML RARA. Next point, why is it the best prognostic? Because we have therapy against it, which is ATRA. ATRA stands for all trans retinoic acid. We have therapy against it, that is ATRA, all trans retinoic acid. Next point, most common cause of death in M3. Most common cause of death in M3 is DIC. Most common cause of death, DIC. disseminated intravascular coagulation. So I can rephrase this as DIC is most common with which AML? M3. Next, NSE, non-specific esterase. NSE, it is positive in monocytic leukemias. It is positive in monocytic leukemias and M3. We have already seen this. We also know that monocytic leukemias are M4 and M5. Next point, how do we diagnose monocytic leukemias? Which CD markers? They are CD14 positive, CD64 positive. Monocytic leukemias, the markers are 14 and 64. Next point, most common AML associated with chloromas. Most common AML associated with chloromas, M2. Next, most common AML associated with bone marrow fibrosis. M7. Next, most common AML with leukemia cutis. Leukemia cutis, it is involvement of the skin with leukemic nodules. Leukemia cutis, M5. Most common AML with leukemia cutis, M5. Next question, most common leukemia associated with Down syndrome. Most common leukemia associated with Down syndrome. Answer ALL. Please see the question properly. Most common leukemia with Downs, ALL, whereas most common AML with Down syndrome is M7. So see the difference in the question properly. Most common leukemia with Downs, ALL, whereas most common AML with Downs is M7. Last point. This gets us to most common leukemia in Downs in children less than 3 years. This is again M7. This has not been asked till now but can very well be asked. So see the difference in the three statements. Most common leukemia in Downs is ALL, whereas AML in Downs is M7, which was the least common overall. But most common leukemia in Downs in less than 3 years of age is again M7. Done. This finishes question 24. Non-specific esterase. We have also looked at the main Fab classifications of AML. This gets us to the next question, that is question 25. This gets us to the next one, that is question 25. Endothelial molecule involved in transmigration of cells is ICAM. The answer is C, that is ICAM. The answer is C, that is ICAM. So before we go further, let us make a table. You very well know that in what are the steps of inflammation? Let's go point wise. The steps of inflammation, they are first vasodilation takes place. Because of vasodilation, the leukocytes come to the margin of vessel wall, that is margination. The flow becomes sluggish and leukocytes come to the margin, that is margination. This in turn is followed by rolling, that is attachment and detachment of leukocytes on the vessel wall, rolling leading to adhesion. After adhesion, the next step is diapedesis. Diapedesis means the leukocytes, they come out of the vessel wall. Diapedesis in turn leading to chemotaxis. After coming out of the vessel wall, they go to the site of inflammation, chemotaxis. After reaching the site of inflammation, they have to recognize the microbe. Recognition of the microbe followed by phagocytosis and killing. Followed by phagocytosis and killing. These are the steps of inflammation. So, how is rolling and adhesion taking place? Rolling में the leukocyte receptor, that is receptor on the leukocytes, will attach to something present on endothelial cells. So let us make that table. Let's make the table of leukocyte receptor, and endothelial receptor. Leukocyte receptor and endothelial receptor. Starting with rolling. The leukocyte receptor responsible for rolling is sialyl Lewis X glycoprotein. Sialyl Lewis X glycoprotein present on leukocytes, which in turn binds to selectins present on endothelial cells, which in turn binds to selectins present on endothelial cells. When rolling is taking place, it converts low affinity integrins. It converts low affinity integrins to high affinity integrins. It converts low affinity integrins to high affinity integrins. As a result, adhesion occurs. Because of binding of high affinity state integrins with integrin ligands. Adhesion occurs because of binding of high affinity state integrins with integrin ligands. Next point, integrin ligands. I can subdivide them into two types. There are two main integrin ligands, which are ICAM and VCAM. ICAM, this is CD11A/CD18 versus VCAM, which is VLA4 integrin. Next point, what is the role of ICAM? One, we have already seen, it is useful for adhesion and integration. It is useful for adhesion and arrest of cells, followed by transmigration of leukocytes. Extremely important, and this was what was asked. ICAM transmigration versus VCAM, which predominantly plays a role in adhesion only. This is margination, rolling and adhesion. After that, the next step was diabetes. So just one word with this, it is mainly mediated by, the most important mediator for diabetes is CD31 or PCAM. PCAM stands for platelet endothelial cell adhesion molecule. So CD31 or PCAM. Done. This is question 25. This gets us to the next question, that is question 26. This gets us to the next one, that is question 26. First point, let us have a look at it. 1517 is associated with, we have just seen it in the previous question, translocation 1517, it is fusion transcript for M3, that is PML RARA. Translocation 1517, it is PML rara fusion transcript. PML rara fusion transcript. Next point, let us see more points with this. We have already seen best prognosis 15-17 PML rara. You also know most common why is it best prognosis, because we have therapy against it, that is ATRA, all trans retinoic acid. You also know that the most common cause of death in M3 is DIC. So we rephrased it as DIC is most common in M3. We have seen these points. So this gets us to the next point in this, that is good prognostic markers. This gets us to the next point, that is good prognostic markers in AML. Good prognostic markers in AML. There are three main good prognostic markers, which are, the first you already know is translocation 15-17. Translocation 15-17. Fusion transcript PML rara. Fusion transcript PML rara seen in M3. Seen in M3. Next, the next translocation which is good prognosis is translocation 821. Translocation 821. Fusion transcript AML ETO. Fusion transcript AML ETO. Just give me a sec, guys. Just a sec. There's slight problem in this. Okay. So fusion transcript AML ETO. Also, I'm so sorry. Wait, this slightly got muddled up. Let me write this again for you. So translocation 15-17 PML rara. Next translocation was translocation 821. Fusion transcript AML ETO, also called as RUNX1 T1. This unfortunately has to be remembered, no doubt about it. Translocation 821, RUNX1 T1, most commonly seen in M2. Most commonly seen in M2. And the last is inversion 16. Inversion 16. The fusion transcript is CBFB MYH11. Inversion 16. The fusion transcript is CBFB MYH11. Even if you don't remember this, I am okay with it. The others have to be remembered. Inversion 16 seen in M4. And which special subtype of M4? M4 with eosinophils. M4 with eosinophils. Comfortable? Next point. Now what are we studying? We are studying AML. AML blasts should be more than or equal to 20%. That is the basic rule of making something as acute leukemia. Presence of blasts more than or equal to 20%. Except in these three. If any one of this is present, and even if blasts are less than 20%, diagnosis is AML. Diagnosis is AML. Done. This is AML. So you know translocation 15-17 M3. Next point. Next, before we go further, let us have a look at the next question. That is question number 27. This gets us to the next question, that is question 27. Defective DNA repair is associated with, and the answer is B, that is Ataxia telangiectasia. Question 27. Defective DNA repair, it is associated with Ataxia telangiectasia. Ataxia telangiectasia. So before going further, let us have a look at this inheritance pattern. Ataxia telangiectasia, it is autosomal recessive in nature, present on chromosome 11. Chromosome 11. Next point, clinically it is associated with ataxias. The name tells you that. Clinically associated with ataxias, dysarthria, ataxias, dysarthria with pulmonary infections, with pulmonary infections. Next point, it is a DNA repair defect. It is a defect in DNA repair. That is, it is a DNA repair defect, as a result of which the cells are highly susceptible. As a result of which the cells are highly susceptible to radiation induced damage. They are highly susceptible to radiation induced chromosomal damage. They are highly susceptible to radiation induced chromosomal damage. So it is a DNA repair defect. Because of radiation induced chromosomal damage, it is also associated with tumors. Because of radiation induced chromosomal damage, it is also associated with the development of tumors. Last point, why is all this occurring? It is related to maldevelopment of the thymus. Ataxia, telangiectasia, it is related to maldevelopment of the thymus. This is ataxia, telangiectasia, autosomal recessive, chromosome 11. Next, this gets us to the next question, that is question 28. This gets us to question number 28. Which does not present with systemic eosinophilia with renal failure? Let's see option wise. Drug-induced interstitial nephritis seen, etheroembolic renal damage, okay, contrast allergy, the minute allergy, eosinophilia, renal damage, fair enough. So the answer is A, that is PAN. The answer is A, that is PAN, polyangiitis nodosa. This is a vasculitis. So let us see PAN in detail. Firstly, it is a vasculitis. So starting with classification of vasculitis, what is PAN? Classification of vasculitis on the basis of size of the vessel. Starting with classification of vasculitis on the basis of size of the vessel, I can divide it into three types, that is small vessel vasculitis, medium vessel vasculitis, and large vessel vasculitis. I can divide it into three types, small vessel, medium vessel, and large vessel. The small vessel vasculitis are microscopic PAN, the small vessel are microscopic PAN, venous granulomatosis, microscopic PAN, venous granulomatosis, and Churg-Strauss syndrome. Microscopic PAN, venous, Churg-Strauss, and HSP. HSP stands for Henoch-Schönlein purpura. HSP. The medium vessel vasculitis are PAN and Kawasaki disease. The medium vessel are PAN and Kawasaki disease, whereas the large vessel vasculitis are giant cell arteritis. Large vessel are giant cell arteritis and Takayasu syndrome. Giant cell arteritis and Takayasu syndrome. This is the classification of vasculitis on the basis of size of the vessel. On the basis of size. This is the most commonly used classification scheme. And this has a special name to it called as Chapel Hill nomenclature. This has a special name to it called as Chapel Hill nomenclature. The next way to classify vasculitis is on ANCA. ANCA stands for anti-neutrophil cytoplasmic antibody. Anti-neutrophil cytoplasmic antibody. Anti-neutrophil cytoplasmic antibody. ANCA. ANCA, it is of three types. C ANCA, that is cytoplasmic ANCA. P ANCA, that is perinuclear ANCA, and atypical ANCA. ANCA, it is of three types: C ANCA, P ANCA, and atypical ANCA. In C ANCA, the antigen in C ANCA is proteinase 3. The antigen is proteinase 3 versus P ANCA, where the antigen is MPO, that is myeloperoxidase. In atypical ANCA, the antigen is unknown. Next point, diseases associated with C ANCA, they are Wegener's granulomatosis. The disease seen in C ANCA, Wegener's granulomatosis, easy to remember, cow, COW, so C ANCA, Wegener's. Whereas P ANCA, the diseases are microscopic pan and Churg-Strauss syndrome. Microscopic pan and Churg-Strauss. So the small vessel vasculitis are ANCA positive. C ANCA, Wegener's, microscopic pan, Churg-Strauss, P ANCA. Atypical ANCA, the diseases are IBD, inflammatory bowel disease, PSC, primary sclerosing cholangitis, and rheumatoid arthritis. That is atypical ANCA. Last point, the last way to classify vasculitis is granulomatous versus non-granulomatous. So the granulomatous vasculitis are first is obviously Wegener's granulomatosis. The name has granuloma in it, Wegener's. Next, Churg-Strauss syndrome. Chug is coughing. Coughing is associated with asthma, eosinophilia, and granulomas. Churg-Strauss. Next, giant cell arteritis. Wherever giant cells are present, it is also associated with granulomas. Giant cell arteritis and Takayasu syndrome. So both the large vessel vasculitis are granulomatous. These are the three ways to classify vasculitis: size of the vessel, which is the most commonly used, Chapel Hill nomenclature, ANCA, and granulomatous. Next point, starting with the main one, that is PAN, which was even asked in the question, that is which is not associated with eosinophilia with renal failure. That is PAN, it is not associated with eosinophilia. So PAN, it is a medium vessel vasculitis, you very well know. Next point, PAN, it is a colorful disease to have. If you know this, you will know everything about it. How? It is a colorful disease. So the first point is it has an acute phase and a chronic phase. Acute phase is associated with inflammation, whereas chronic phase shows fibrosis. That is obvious. Along with inflammation, acute phase is also associated with fibrinoid necrosis. This point is important. It is also associated with fibrinoid necrosis. Next, it is a colorful disease. So acute and the chronic phases coexist. Means in the body, somewhere there will be an acute phase, somewhere else there would be a chronic phase. Acute and chronic phases coexist. Next point, PAN, it is a colorful disease to have because like colorful people branching onto others, it has a predilection for branch points. meaning where the vessels branch, pan is more commonly seen. Last point, it does not involve the full circumference of the vessel. It has a circumference, it does not involve the full circumference. It is semi-circumferential in involvement. It is semi-circumferential in involvement. This is pan. This is pan. Last point, organs affected. Organs affected, kidney and visceral vessels. Organs affected, kidney and visceral vessels are affected. Please note, in kidney it is not associated with eosinophilia. That was the answer. Another important point in this is, put a double star and write down, lungs are spared. In pan, lungs are spared. Easy to remember. Lungs are associated with alveoli, which has small vessels with it. So lungs are involved with small vessel vasculitis, not with large vessel, that is not with pan. Next, this was pan. This gets us to the next option that was asked in the question, that is contrast induced nephropathy. This gets us to the next option, that is contrast induced nephropathy. The name tells you everything. The name tells you everything. Contrast induced. So it is nephropathy. It is impairment of renal function. It is associated with impairment of renal function. When within 48, impairment of renal function within 48 to 72 hours of IV contrast. Within 48 to 72 hours of IV contrast. Easy to remember, 2 to 3 days, 48 to 72 hours. Next point, it is associated with eosinophilia. It is associated with eosinophilia. This is contrast induced nephropathy. The next is acute interstitial nephritis. The next option was acute interstitial nephritis. Acute interstitial nephritis. Acute interstitial nephritis. This again, let me slightly enlarge this so that the font size is bigger. Acute interstitial nephritis. This is better. This presents as acute renal failure. This presents as acute renal failure. Why? Because of associated drugs. Acute renal failure because of drugs. Acute interstitial nephritis. Next point, the urinary findings. Microscopically, in the urine, it is associated with pyuria, hematuria, and WBC CAS. In the urine, it is associated with hematuria, pyuria, and WBC CAS. Next point, it can also be associated with infections and sarcoidosis. So the main cause was drugs, can also be associated with infections and sarcoidosis. Next point, signs of allergy. Signs of allergy are present in some patients. And when we mean by, what do we mean by signs of allergy? That is maculopapular rash. Signs of allergy, that is rash. Which rash? Maculopapillary rash. Maculopapular rash, papular rash, and eosinophilia. Maculopapular rash and eosinophilia. So we have seen that eosinophilia would be associated with all except pan. Done. Next, this gets us to the next question, that is question 29. This gets us to the next one, that is question 29. All of the following are mitochondrial diseases except Leigh, Pearson's and KSS. They are mitochondrial except D, that is Leigh-Fromeny syndrome. So question 29, the answer is D, that is Leigh-Fromeny syndrome. Leigh-Fromeny syndrome. So first point, this gets us to the mitochondrial diseases associated. So starting with mitochondrial inheritance. First point, it is mitochondria. We inherit mitochondria from our mother or father? Mother, obviously. So it is maternal inheritance. Mitochondrial inheritance. It is maternal inheritance. Next point, diseases associated with mitochondrial inheritance. The most common being Mela's syndrome. Diseases associated, most common is Mela's syndrome. Mela's stands for mitochondrial encephalopathy. Mela's stands for mitochondrial encephalopathy. Lactic acidosis and stroke-like symptoms. So Mela's syndrome, that is mitochondrial encephalopathy, lactic acidosis and stroke-like symptoms. The next disease, it is associated with Pearson's syndrome. Pearson's, this is pancreatic insufficiency, lactic acidosis and pancytopenia. Pearson's syndrome, pancreatic insufficiency, lactic acidosis and pancytopenia. Next, the next disease associated with mitochondrial inheritance is Leigh disease. Next is Leigh disease or NARP. NARP stands for neurogenic ataxia. NARP stands for neurogenic ataxia retinitis pigmentosa. Neurogenic ataxia retinitis pigmentosa, Leigh disease or NARP. Next is LHON, that is Leber's hereditary optic neuropathy. LHON, Leber's hereditary optic neuropathy. LHON. Next is CPEO, that is chronic progressive external ophthalmoplegia. CPEO, chronic progressive external ophthalmoplegia. Next is MRF. Which is myoclonic epilepsy. MRF, myoclonic epilepsy, ragged red fibers. Myoclonic epilepsy, ragged red fibers. MRF. And the last is KSS, that is Kearns-Sayre syndrome. KSS, that is Kearns-Sayre syndrome. These are the diseases associated with mitochondrial inheritance. You very well know mitochondrial inheritance, it is a maternal inheritance. So the answer was Li-Fraumeni syndrome, that is P53 mutations. It is not a mitochondrial inheritance disease. Next, this gets us to the next question, that is question 30. That is question number 30. Let us have a look at that. Staining used for apoptotic bodies is annexin 5. The answer is B, that is annexin 5. Apoptotic bodies, we use the stain annexin 5. What do we mean by this? Annexin 5, it stains annexin 5, it stains phosphatidylserine. It stains phosphatidylserine which is present on the outer side of the membrane. So this is an immunostain for apoptosis. This is an immunostain for apoptosis, annexin 5. Next point, what do we mean by stains phosphatidylserine? Now, for this we need to know the mechanism of apoptosis. Apoptosis, or let me rephrase it as apoptotic bodies. Apoptotic bodies, they are removed by macrophages. Apoptotic bodies are removed by macrophages by, what is the action? They are removed by macrophages by thrombospondin receptors. By thrombospondin receptors. Firstly, thrombospondin receptors, they are expressed on apoptotic cells. They are expressed on thrombospondin receptors which are expressed on apoptotic cells. They are expressed on apoptotic cells. These thrombospondin receptors, they are recognized by TS receptors. They are recognized by thrombospondin receptors which are present on macrophages. First point. Next, it is also removed by macrophages by phosphatidylserine. How? Phosphatidylserine, this is flipped from inner to the outer surface. It is flipped from inner to the outer surface of the RBCs, which in turn is eaten up by macrophages. So two main mechanisms by which macrophages remove the apoptotic bodies. First was thrombospondin receptors, recognized by TS receptors, and phosphatidylserine, which is eaten up by macrophages. So for staining of apoptosis, we stain phosphatidylserine by using annexin 5. Next, this gets us to the next question, that is question 31. This gets us to the next one, that is question 31. All are true about xanthogranulomatous reactions except xanthogranulomatous reactions, they are the foamy reactions. So giant cells are present, xanthogranulomatous giant cells, true. Yellow nodules, true. Cholesterol laden macrophages, true. So the answer is A, that is associated with TB. This is false. Xanthogranulomatous reactions associated with TB. This is false. So before we go further, this gets us to the various types of giant cells that we see in pathology. What is a giant cell? Giant cell, it is a cell with multiple nuclei. Cell with multiple nuclei. First point, starting with TB, that is Langerhans giant cell. Langerhans giant cell seen in tuberculosis. What is the special feature of Langerhans giant cell? It shows the presence of nuclei which are arranged at periphery. Nuclei arranged at periphery of the cell. This is a Langerhans giant cell. Nuclei arranged at the periphery, giving it the classical horseshoe shaped appearance. Giving it the classical horseshoe appearance. This is Langerhans giant cell. Next, the next type of giant cell, next is measles. Measles, which is associated with Waldenfinkel-Day giant cell. Measles, Waldenfinkel-Day giant cell. Next is xanthogranulomatous reactions. Next is xanthogranulomatous reactions. This was what the question was on, xanthogranulomatous inflammation or xanthogranulomatous reactions. First point, the giant cell seen in this, let's go pointwise in this. The giant cell seen in this is the Taunton type of giant cells. The fancy name of the giant cell is Taunton giant cells. Next point, it presents as yellow lobulated masses. Xanthogranulomatous inflammation presents as yellow lobulated masses which are more common after the 5th decade. More common after the 5th decade. Next point, in kidney it is associated with Proteus infections. In kidney it is associated with Proteus infections and obstruction to the outflow. Proteus infections and obstruction to the outflow. Next point, inflammation. It also microscopically includes a large number of foam cells. It includes a large number of foam cells and macrophages. Foam cells and macrophages. This is xanthogranulomatous reactions. So, which all pathological giant cells have we seen till now? Langerhans giant cell, TB, measles, Waldenfinkel-Day, xanthogranulomatous reactions, that is Taunton giant cell. The next giant cell is a foreign body giant cell. The next pathological giant cell is a foreign body giant cell. What do we mean by a foreign body? Foreign body, it can be suture material or talc powder. Suture material or talc powder. How do we recognize a foreign body giant cell? Microscopically, it is refractile under polarized light. Microscopically, it is refractile under polarized light. That is a foreign body giant cell. Next, the other pathological giant cells, they are the RS cells, Reed-Sternberg cells, RS cells, and tumor giant cells. RS cells and tumor giant cells. I am not going to go into the details of these, this Done. This gets us to the next question, that is question number 32. This gets us to the next one, question 32. First site of calcium deposition in every cell is mitochondria, except in kidney. Except in kidney. This is a factual question. The first site of deposit in every cell of calcium is mitochondria except kidney. Why? Why? Because in kidney calcium deposition, it takes place in basement membrane of tubules. In kidney, calcium deposition starts in basement membrane of tubules, not in the mitochondria. This is important. Next, this gets us to the next question, that is question 33. Question 33. Best defined pattern recognition receptors are, and the answer is A, that is toll-like receptors. The best defined pattern recognition receptors are toll-like receptors. They are TLRs or toll-like receptors. What do we mean by this? Toll-like receptors, they recognize molecules. Toll-like receptors, they recognize molecules that are broadly shared by pathogens, but distinguishable from host cells. They recognize molecules that are shared by pathogens but are distinguishable from host cells. First point. So they help in the recognition of pathogens. Next point. Three subgroups are present. In toll-like receptors, it has three subgroups. TLRs, it has three subgroups, which are, starting with the first one, subgroup 1 toll-like receptors. They are receptors for interleukins. Subgroup 1, they are receptors for interleukins produced by macrophages, monocytes, and dendritic cells. So subgroup 1, they are the receptors for interleukins. The next subgroup, that is subgroup 2. They are the classical toll-like receptors. What do we mean by classical toll-like receptors? They bind to molecules of microbial origin. So subgroup 1 was a receptor of interleukin 1, whereas subgroup 2 are the classical ones. They bind directly to molecules of microbial origin. Versus subgroup 3. They are exclusively subgroup 3. They are exclusively cytosolic. In nature. That is, they are present in the cytoplasm. They are exclusively cytosolic, and they mediate signaling. From proteins of subgroup 1 and 2. They mediate signaling from subgroups 1 and 2. So subgroup 1 was interleukin binding. Subgroup 2 bound directly to the microbial or molecules of microbes, whereas subgroup 3, they mediate signaling from subgroup 1 and 2. These are the toll-like receptors. Next, this gets us to the next question, that is question 34. This gets us to the next one, that is question 34. chronic granulomatous disease is due to decrease in, now point is they've even mentioned it as X-linked, so it is due to a decrease in GP91 FOX. The answer is D, that is GP91 FOX. GP91 FOX. What do we mean by this? Before we go further, let us first have a look at pathways of killing. See, we were done with the steps of inflammation: margination, rolling, adhesion, diabetes, it comes out of the vessel wall, chemotaxis, phagocytosis, and killing. The main pathway of killing is the NADPH oxidase pathway. The main pathway of killing is the NADPH oxidase pathway, also called as phagocyte oxidase pathway. Also called as phagocyte oxidase pathway. First point. Next point, NADPH oxidase. This is a ROS mediated damage, reactive oxygen species mediated damage. Next point, it is a ROS mediated damage. Next point, NADPH oxidase. It is a complex of numerous proteins. It is a complex of numerous proteins which in the healthy state, which in the healthy form is present in active or inactive form. They are inactive form. They are present in an inactive form. They become activated in inflammation. They become activated in inflammation. First point, it is a complex of numerous proteins which in the healthy state is present in an inactive form. It becomes activated in inflammation. Next point, NADPH oxidase. How does it act? Oxygen by the action of NADPH oxidase. Oxygen by NADPH oxidase is converted to superoxide anion. It is converted to superoxide anion. This superoxide anion is then acted upon by superoxide dismutase, SOD, superoxide dismutase, leading to the formation of H2O2, which is then acted upon by catalase, which is then acted upon by myeloperoxidase and chloride, leading to the formation of hypochlorous anion, which in turn leads to killing. This is the NADPH oxidase pathway. Now let us see the questions associated with it. First question, superoxide dismutase. Is it a pro-oxidant or an antioxidant? It is an antioxidant. Superoxide dismutase, it is an antioxidant. Why? Because superoxide dismutase, it converts a free radical, that is superoxide anion, to H2O2. It is an antioxidant. If the person was healthy, this H2O2 will be acted upon by catalase and peroxide, catalase or glutathione peroxide, H2O plus O2, antioxidant. Next point, any defect in this, that is defect in NADPH oxidase pathway, leads to chronic granulomatous disease. So this gets us to chronic granulomatous disease. First we have seen the pathway, NADPH oxidase pathway. Now defect in NADPH oxidase pathway leads to chronic granulomatous disease. CGD, chronic granulomatous disease. First point, NADPH oxidase was a complex of numerous proteins. However, the pathologically important are 4: GP91 Fox, 67 Fox, 47 Fox and 22 Fox. It's nothing, it's just the names of the proteins. The smallest and the eldest, these are the proteins of integral membranes. These are the proteins of integral membranes, that is, they form the boundaries, versus 67 and 47, which are the cytosolic proteins, versus 67 and 47, which are cytoplasmic in nature. Next point, any defects in proteins of integral membranes, it is X-linked recessive in nature. It is X-linked recessive, versus the other two, which is autosomal recessive in nature, versus the other two, which is autosomal recessive. Next point, so in the question you were asked which is X-linked recessive chronic granulomatous disease, GP91 Fox defect. Next point, as such, even if it was not mentioned as X-linked recessive, let us just assume if chronic granulomatous disease was asked with these options, which one will you mark? GP91 Fox. Why? Because defects in these are more common. So if you are asked the inheritance pattern of this, of chronic granulomatous disease, it is X-linked recessive. This is the most common inheritance pattern. Last point, test for CGD. Last point, test used for chronic granulomatous disease. The most commonly used test is the nitroblue tetrazolium test. Most commonly used is the nitroblue tetrazolium test, NBT, nitroblue tetrazolium test. Nitroblue tetrazolium in presence of free radicals. Nitroblue tetrazolium in presence of free radicals is converted to formazan. In presence of free radicals is converted to formazan. So the question that is asked is, if the test is positive, is the patient diseased or healthy? The patient is healthy. Why? Because test is positive means formazan formation is taking place. Formazan is forming means free radicals are forming, and this is the role of NADPH oxidase, generation of free radicals. So if free radicals are forming means NADPH oxidase is okay. So if the test is positive, the person is healthy in nature. Done. This is question 34, chronic granulomatous disease. This gets us to the next question, that is question 35. This gets us to the next one, that is question 35. Karyotyping under light microscope is by G banding. Karyotyping under light microscope is by G binding. What do we mean by this? So let us have a look at types of banding. The first is, starting with the first one, that is G banding. G banding, this is obtained with Giemsa stain. Following digestion of chromosomes with trypsin. Obtained with Giemsa stain following the digestion of chromosomes. With trypsin. First point, G banding, obtained with Giemsa stain following digestion of chromosomes with trypsin. Next point, This shows us two regions. It shows two bands, the light and the dark bands. So it shows two bands, the dark bands and the light bands. Dark bands and light bands. G banding, James stain se ho raha hai, obtained with James stain following digestion of chromosomes. So it shows two bands, dark and light. Dark bands, these are heterochromatic. These are heterochromatic, late replicating, and AT rich. These are heterochromatic, late replicating and AT rich. Versus light bands which are euchromatic, early replicating and GC rich. First point. Next, this produces, how many bands would we see normally? Normally, G banding, it shows 300 to 400 bands in a normal human genome. Normally it shows 300 to 400 bands. Next, the next type of banding. So this was the first one, G banding. The next type of banding is R banding. Next is R banding. So G binding was Jimsa. R stands for reverse binding. R stands for reverse binding. Here the dark regions are euchromatic. This is opposite of Jimsa, reverse of Jimsa. Here the dark regions are euchromatic. Whereas the light regions are heterochromatic. This is opposite. Next, the next banding is C banding. It stains centromeres. C banding stains centromeres. So, what does it bind to? It binds to constitutive heterochromatins. And it stains centromeres. And binds to constitutive heterochromatin. Next, the next is Q banding. In this, we use quinacrine for staining. In Q banding, we use quinacrine for staining. So which all have we seen till now? G banding, Jimsa. R banding, reverse banding. C binding was for centromeres, and the next is Q binding. That is, in this we use quinacrine for staining. Next, this is similar. The pattern is similar to G banding. And last is T banding, which is to visualize telomeres. T banding. This is to visualize telomeres. These are the banding techniques. This is all factual. G banding, R banding, Q banding, T banding, and C. C was for centromeres. Done. Next, this gets us to the next question, that is question number 36. This gets us to the next one, question 36. MYC2 mutation is associated with Ewing's sarcoma. It is associated with Ewing's sarcoma. MYC2, Ewing's sarcoma. So before we go further, this gets us to a miscellaneous topic, that is tumor markers for various tumors. So starting with tumor markers. Can I now safely say that tumor markers, they are used to make a diagnosis of tumor? No. See, an example of a classical tumor marker is AFP, alpha fetoprotein. It is a tumor marker for HCC and it is also elevated in yolk sac tumors. So I cannot use AFP to make a diagnosis of either. On the other hand, so let us write it pointwise, tumor markers, they are not used to make a diagnosis. They are not used to make a diagnosis of the tumor, but they are used for screening of tumors and tumor monitoring. They are not used to make a diagnosis, but are used for screening of tumors and tumor monitoring. Tumor monitoring means patient has come to you, have operated, given her chemotherapy. After that, you will keep her on continuous AFP follow, because when the tumor reoccurs, AFP would be elevated again. Next, starting with tumor markers, starting with the first tumor marker, AFP, alpha fetoprotein. Let us make the list here only. It is elevated in HCC, which is primary malignant liver cancer in adults. What is the liver malignancy in children called as hepatoblastoma? Next, it is also elevated in ovarian tumors. Most common ovarian tumor being yolk sac tumor. Next, other causes of elevation are chronic hepatitis C virus infections. Next, cirrhotic background liver nodules. It is also elevated in cirrhotic background liver nodules and fetal distress and death. I am not writing that because we are writing the tumor markers. Next, the next tumor marker is beta HCG. Elevated in choriocarcinoma. Next, beta 2 microglobulin. Elevated beta 2 microglobulin. This is a poor prognostic factor in multiple myeloma. It is a poor prognostic factor in multiple myeloma. Next, PSA, prostate specific antigen. PSA, obviously prostate cancer. Next, CEA, carcinoembryonic antigen. Increased in carcinomas of colon, lungs and GIT. Next, we have already seen MIC2, that is Ewing's sarcoma. This was the question. This we have already seen, Ewing's sarcoma. Next, put 2 dots in front of it and write it here only. Which is the CD marker positive in Ewing's? It is CD99 positive. Ewing's sarcoma, CD99 positive. Next, the next is the CA markers, that is CA125, which is positive in ovarian cancers. CA15-3, that is breast cancer. CA15-3, breast cancer. CA19-9, pancreatic cancer. CA19-9, pancreatic cancer. Add one more here, CA72-4, gastric cancer. Though this has not been asked till now, but can very well be asked. CA125 ovarian, 15.3 breast cancer, 19.9 pancreatic, 72.4 gastric cancer. Coming to the last one, that is neuron specific enolase. Coming to the last one, that is neuron specific enolase. It is again positive in Ewing sarcoma, small cell carcinoma lung, Ewing sarcoma, small cell carcinoma lung, and neuroblastomas. Done. This is question 36. So MEC2, it is with Ewing's sarcoma. Next, this gets us to the next question, that is question 97. I'm so sorry, that is question 37. Question 37. Stain of mineralization of newly formed osteoid. The answer is C, that is labeled tetracycline. The answer is C, that is labeled tetracycline. For newly formed osteoid, labeled tetracycline. So before we go further, let us have a look at other options. Von Cosa, Elizarin Redis, repeatedly asked calcium. Fluorescence, that is a technique, immunofluorescence, labeled tetracycline. Even if you were not aware of anything in this, the answer was this. So before we go further, we will first have a look at what is labeled tetracycline, and then we will go on to the stains which are used with other diseases. Starting with labeled tetracycline, let us see the features. Now, bone, it has a unique feature that remodeling can be quantified. In bone, remodeling can be quantified. In bone, remodeling can be quantified. Guys, just give us 1 sec. Remodeling can be quantified in a bone. First point. Next point, how we do so? By incorporation of tetracycline. We quantify remodeling by incorporation of tetracycline into newly formed bone. By incorporation of tetracycline into newly formed bone. That is, we incorporate the tetracycline in vivo, that is inside the body, serving as time markers. With this will be incorporated and this serves as time markers. So for this we use labeled tetracycline. Next point, this gets us to the master list of stains used in pathology. This gets us to the master list of stains used in pathology. Which is the most commonly used stain in pathology? HND, hematoxylin and eosin. The other stains are, let us start with renal stains. Stains used in pathology, renal stains. The first is PAS. The first renal stain is PAS, that is periodic acid shift. PAS, that is periodic acid shift. This stains the basement membrane, mesangial matrix. This stains basement membrane, mesangial matrix and tubular epithelium. This stains basement membrane, mesangial matrix and tubular epithelium. Next point, this is the most commonly used stain in pathology, and this is the most commonly used stain in renal biopsy. Most common and most useful. Both. So PAS, periodic acid shift, stains the basal membrane, mesangial matrix and tubular epithelium. Next point, this is the most common and the most useful stain in renal biopsy. Next, the next stain for kidney is Mason's trichrome. Mason's trichrome. The name tells you everything. Trichrome, that is 3 colors. The 3 colors are blue-green for collagen, red for muscle and black for nuclei. Trichrome, 3 colors, blue-green collagen, red muscle, black nuclei. And the last is SM, that is silver methenamine. It is used to differentiate hyaline deposit from sclerosis. Sclerosis is SM positive. So what have we done till now? Firstly, we saw the use of labeled tetracycline in the bone. Then we came on to the stains used in pathology. Most common was HE. Then we made a list of 3 renal stains: PAS, SM, MT. Next are the other miscellaneous stains used in pathology. Starting with bile, we use modified Fauchert's stain. Modified word can be used later also, bile Fauchert's. Next, calcium, extremely important. Calcium, this was given in your options also and again has been repeatedly asked. I can divide it into 2 types: most common and most specific. Most commonly used for calcium is von Cosa stain. Whereas most specific is alizarin redis. Next, copper. We again use 2 stains, that is Orcine stain, and modified rhodamine stain. Next, please differentiate. Modified rhodamine is for copper, whereas Orcine and modified rhodamine is for copper, whereas hepatitis B surface antigen is the Shikata Orcine stain. Hepatitis B surface antigen. Next, fat. I can divide this into 2 types: fresh and fixed. Fresh fat we use oil red O, whereas fixed is Sudan black. Fat, fresh and fixed. Next, H. pylori. We use silver stains, and the most common silver stain used for H. pylori is the Walden-Stary stain. Silver stains, most common being Walden-Stary. Last point, amyloid. 3 stains, that is congruent, PAS and thioflavin T. Next point, extremely important. What is the color of amyloid with congruent? Color of amyloid. Please put a double star and write down. It is brick red or salmon red in color. brick red or salmon red in color. Please don't mark it as apple green. With color of amyloid with Congo red, it is brick red or salmon red. Apple green is the birefringence. Apple green is the birefringence under polarized light. Birefringence under polarized light with Congo red. Birefringence under polarized light with Congo red. So when the color of amyloid is asked, we are talking about light microscopy, not polarized light with Congo red. Last point, color of amyloid with thioflavin T, it is yellow in color. This takes care of your first miscellaneous topic. So we have covered two miscellaneous topics till now. The first one was various translocations and the tumor markers and the genes associated, and the second is stains used in pathology. Next, this gets us to the next question, that is question 38. This gets us to the next question, that is question number 38. Let us have a look at it. Bone marrow biopsy, bone marrow picture of a patient with anemia is given. What is the diagnosis? Now, what we see here is a giant, what we see here is the presence of a giant pronormoblast. Wait, let me mark it for you. This is a cell of erythroid series. And which cell is this? This is a giant pronormoblast. Giant pronormoblast, firstly, and this is pathogenic of, this is a cell of erythroid series, giant pronormoblast, and is pathogenic of parvovirus infections. Parvovirus infection, parvovirus B19 infection. Let us see more such cells. What we have here is the predominance of erythroid cells. This is the bone marrow with all these large cells, large erythroid cells, large nucleus, scant blue cytoplasm. All these are the giant pronormoblasts seen in parvovirus infections. Seen in parvovirus infections. So before we go further, let us have a look at parvovirus infection. So question number 38. Question number 38. The answer is A, that is parvovirus infection. Giant pronormoblasts seen in parvovirus infections. Associated with which hemolytic anemia? Parvovirus infections, they are associated with sickle cell anemia. Sickle cell anemia. So before we go further, let us have a look at sickle cell anemia in slightly more detail. First point, sickle cell anemia, I need not even write that it is autosomal recessive associated with point mutations in 6th codon of beta chain, as a result of which glutamic acid is replaced by valine. You very well know this. This in turn leads to the formation of hemoglobin S. Now, even if HbS is formed, what is the problem? Hemoglobin S, it polymerizes on deoxygenation. It polymerizes on deoxygenation. Now it is the job of the RBCs to take oxygen from lungs and give it to the peripheral tissue. But this is polymerizing. So is this reversible or irreversible? Initially this polymerization is reversible, but repeated cycles of oxygenation and deoxygenation lead to the formation of irreversible sickle cells. Repeated cycles of oxygenation and deoxygenation lead to the formation of irreversible sickle cells, that is ISCs. Next point, so even if they are formed, so what is the problem? Problem is starting with clinical features. Firstly, it is associated with vaso-occlusive crisis. Vaso-occlusive crisis, that is occlusion of various vessels. What are the sites of these vaso-occlusive crises? Dactylitis. Dactylitis means bone pains. Dactylitis of bones of hands and feet. It is associated with dactylitis of the bones of hands and feet. Next, because of occlusion of the cerebral vessels, stroke and retinopathy. It is associated with stroke and retinopathy. Next, it is also associated with priapism. What is priapism? Painful erection. Priapism, painful erection. And in the conjunctival vessels, it is associated with the classical comma sign. Comma sign means the conjunctival vessel, it looks like a comma. These are the vaso-occlusive crises. Next, the next crisis that is seen with sickle cell anemia is aplastic crisis. Aplastic crisis, which is associated with parvovirus B19 infections. Parvovirus B19 infections. What does it infect? It infects the erythroid precursors. Where? In the bone marrow, leading to the formation of giant pronormoblasts. This is aplastic crisis, and this was what was asked in the image: giant pronormoblasts, aplastic crisis. Next, the next set of clinical features are the splenic changes. This you very well know. The first change seen in spleen is splenic enlargement. Splenic changes. The first change is splenic enlargement, which occurs because of sequestration of RBCs. Splenic enlargement, which occurs because of sequestration of RBCs. This is followed by multiple splenic infarcts, which in turn lead to autosplenectomy. So, is splenectomy indicated in sickle cell anemia? Do we need to do splenectomy? No. Why do you want to do something the disease will do free of cost? So, splenectomy is not indicated because sickle cell anemia is associated with autosplenectomy. The last clinical feature is sickle cell anemia. It is also associated with increased risk of infections. Sickle cell anemia, it is associated with increased risk of infections. By which organisms? By encapsulated organisms. Increased risk of infections by encapsulated organisms, that is Haemophilus influenzae. Haemophilus influenzae and strep pneumoniae. Haemophilus influenzae and strep pneumoniae. Next point, this again has been repeatedly asked, most common cause of osteomyelitis. Most common cause of osteomyelitis in general population. Most common cause of osteomyelitis in general population is Staph aureus, whereas in sickle cell anemia it is Salmonella. In sickle cell anemia, the most common cause of osteomyelitis is Salmonella. Done. These are the splenic changes and the increased risk of infections. So this takes care of question 38. That is, the image that was shown was of parvovirus B19 infection showing giant pronormoblasts. Next, this gets us to the next question, that is question 39. This gets us to the next one, that is question 39. First point, let us see what it is. Now, 50 male, forget the written question, have a look at the image. It shows you kidney it is showing you the presence of a glomerulus with presence of numerous nodular lesions. Nodular glomerulosclerosis, that is diabetic nephropathy, Kimmel-Stale-Wilson lesions. Look at the other points. Crescent, of course not amyloidosis, no, I'll show you what it looks like. So we have made it as diabetes. Now let us come to the written MCQ. 50 male, blurring of vision, so it is also associated with fundus changes. Urine examination shows proteinuria, fundus shows dot and blot hemorrhages, microaneurysms, cotton wool spots. Even without all this, the image based diagnosis was KW lesions, diabetic nephropathy. So question 39, the answer is A, that is Kimmel-Stale-Wilson mesangial nodules or lesions. KW lesions, Kimmel-Stale-Wilson mesangial nodules and lesions. First point, before I go further, let us have a look at diabetic nephropathy. Diabetic nephropathy. First point, diabetes, I can divide the microscopic changes into two types: diffuse glomerulosclerosis and nodular glomerulosclerosis. Diffuse glomerulosclerosis and nodular glomerulosclerosis. Which is more common? Diffuse glomerulosclerosis. More common is diffuse glomerulosclerosis. However, nodular glomerulosclerosis is more specific in nature. It is more specific in nature. Why? Because nodular glomerulosclerosis, it is associated with the formation of Kimmel-Stale-Wilson mesangial nodules or lesions. KW lesions, Kimmel-Stale-Wilson mesangial nodules or lesions. Next point, diabetes, microscopically it is also associated with insudative changes. Microscopically it is also associated with insudative changes. What do we mean by that? This is a pen which is insudating into my fingers, it is entering into my fingers. So if this is the glomerulus of the patient, it is associated with insudative changes, that is, something is entering inside it. It looks like a cap. So the insudative changes are fibrin caps, or it looks like something has been dropped from above, that is capsular drops. exudative changes associated with diabetes, fibrin caps and capsular drops. This is diabetic nephropathy. Next, so before we go further, let us have a look at what it looks like microscopically. Let us see what it looks like microscopically. We have already seen these are the KW, Kimmelsdale-Wilson mesangial nodules or lesions, making this as diabetes. Next, now have a look at this. First, identify the structure, then the parent organ. What you have here is the glomerulus. This is glomerulus with presence of capillaries which are pushed to one side. Capillaries are pushed to one side with presence of crescent on the outside. See, have a look at this. This is the crescent which is forming. This is the crescent which is forming. So it is a crescentric glomerulus. It is a crescentric glomerulus. I hope you will not confuse this with KW lesions at all. The two look totally different from each other. So this is RPGN, rapidly progressive glomerulonephritis or crescentric glomerulonephritis. Next, now have a look at this image. Starting with the light microscopy, what this shows you is, firstly, this is a glomerulus. This is a glomerulus with extracellular pink material which is pointed with arrows. Extracellular pink material. This extracellular pink material, it can be three things. It can either be a hyaline deposit, sclerosis, or amyloid. This extracellular pink material, it can be three things: hyaline deposit, sclerosis, or amyloid. How will we differentiate hyaline deposit from sclerosis? Which stain? SM, silver methenamine. You have just seen that. Next, for amyloid, we use Congo red, which here shows the classical apple green birefringence under polarized light. So this is amyloidosis, amyloidosis kidney. Done. So we have taken care of all the four options, that is KW lesions, crescents, amyloid, and segmental sclerosis. Next, this gets us to the next question, that is question 40. Now forget the written MCQ, forget it. Let us have a look at the immunofluorescence picture. Immunofluorescence, it shows the presence of the classical appearance of MGN, that is membranous glomerulopathy or membranous glomerulonephritis, MGN. Now let us come to the written MCQ. 50 male, massive proteinuria, bilateral pedal edema. What is the diagnosis? Answer is A, that is MGN. Answer is A, that is MGN, membranous glomerulonephritis, MGN. So before we go further, let us have a look at what it looks like. What does it show? MGN or membranous glomerulonephritis. Just a sec, guys, it's giving me slight issues. Let me restart it. So MGN, that is membranous glomerulonephritis. What is the site of deposit? The site of deposit, it shows which deposits? Subepithelial deposits. MGN, it is associated with subepithelial deposits. Next, what is the special name of this deposit? Spikes. So before we go further, put a line on the side and write down humps are seen in PSGN, whereas spikes are seen in MGN. Next point, causes of membranous glomerulonephritis. causes of MGN, again repeatedly asked and important. We have already seen the immunofluorescence. Causes are idiopathic. The most common causes, it is idiopathic in nature. The cause is unknown. Other causes are infections. Infections, easy to remember, having sex is bad. So it's just a mnemonic, don't worry. So the infections associated are hepatitis B, hepatitis C, syphilis, malaria, and schistosomiasis. Syphilis, malaria, and schistosomiasis infections. Next, the other causes are carcinomas, that is carcinoma lung, colon, and melanoma. Carcinomas, carcinoma lung, colon, and melanoma. And the last cause is SLE, that is lupus nephritis. And which class of lupus? Class 5 lupus nephritis, MGN. Done. So this takes care of question 41.